It's time now for the award-winning #1 local talk show in Northeast Pennsylvania, The Sam Lesante Show. Now here's your host, Sam Lesante.
So folks, something happens at home, or you're on work, or you're visiting something, and an emergency happens and you have to be rushed to the hospital. Well, it's trauma, isn't it? We get nervous, we get excited, but we want to make sure that when this happens, we're going to the place that's going to take care of us. So today, I thought it would be a great opportunity for us to learn about the Lehigh Valley Hospital Hazleton Trauma Center. All right, what is it, what happens when these particular emergencies happen. So today we have the medical director of emergency, Dr. Gary Bonfante, and Wally Boyle, who is the paramedic coordinator, who will talk about the trauma center, a lot of things about that. I know I experienced that within the last 30 days, and it was quite interesting, I got to tell you. Gary, thanks for coming on the show.
Thanks for having us.
Wally, nice seeing you.
Nice seeing you, Sammy.
Watch that Paramedic guy, okay?
I'll watch.
Okay. So the trauma center, okay, first of all, Gary, what is the trauma center?
So we're a recognized Pennsylvania Trauma Systems Foundation Level 4 Trauma Center. So the Trauma Center basically has been accredited by the state to serve the community, to provide rapid assessment of the trauma patient. There's about 4 levels, there are 4 levels within the state, from level 1 being your highest to level 4, which is what Lehigh Valley Hazleton is.
Well, wait, so you said level 1 is your highest?
Level 1 is the highest. So
okay, what's level 4 then?
Level 4 would, well, technically be the lowest level that you could be designated at.
Okay. So you are level 4?
We are level 4.
Okay, and what does that mean now?
So a level 4 trauma center, we provide a rapid assessment of the...
Is this good or bad?
This is a good thing.
Okay, that's what I'm trying to figure this out.
This is a very good thing.
All right, I want to talk about good things.
Yeah, no question about it. Yeah. This is a very, very good thing.
So level 4, okay, I'm sorry to interrupt you, but I just want to make that clear, okay? Explain again, what is level 4?
So level 4 provides for the rapid assessment and treatment of a trauma patient. Okay. So whereas we may not have all the subspecialties that a level 1 trauma center has, we have a dedicated team of both providers and nursing staff that will be able to rapidly assess and rapidly treat those patients. So we have the services appropriate for our level of trauma that has been evaluated by the state. We also do things like community outreach, and we also do things such as quality assurance on all our trauma cases. So it's higher level of care than you would get at your, for lack of a better term, regular emergency department that may not be designated as a level 4 trauma center.
What do you consider a trauma, Gary?
So a trauma really could be as simply as anything as somebody's broken their leg or ankle, to something as significant as a major car accident, a major ATV accident, a motorcycle accident, gunshot wound, a stabbing, those types of things. Anything of that nature would be considered a trauma. So it could be something minor, like I mentioned, or it could be something more significant.
So then you have to differentiate when a person's coming in, whether it's a trauma or whether it's a bellyache or a backache or a headache or something that is not.
Sure, yeah. Sure.
How do you determine what is a trauma versus,
Well, sometimes,
someone passes out.
For example, it might come from pre-hospital. So they might be calling us and telling us what they're coming in for, what they found at the scene, or it might be coming from the patient if they're coming in by their own vehicle and what specifically happened. I will admit sometimes the story can be not as clear and we have to make a little bit of a determination, but we always err on the side of what would be most impactful to the patient.
That always is it's interesting because, first of all, people are in Panicville when there is a trauma, okay? I've seen that, okay? I've witnessed that, believe me. And so now what happens is, you try to be as calm as you can, but yet you're really concerned, is this person going to be taken care of now? How long do they have to wait? What's the procedures, et cetera? So how do you determine that as to that person should be coming right in? Then we get the paperwork done later, okay? But, and I understand all the procedures, okay? But I'm looking at the individual person that's coming in with a trauma. They're a nervous wreck. They're concerned. That's where I think training comes in desperately.
Sure. I mean, if somebody comes in via a private vehicle, for example, and, comes in and they're anxious, they're seen, they're brought in, they're seen by a triage nurse and who will make a rapid assessment of why they're there, what happened that caused them to get there, and then we can make a determination, sometimes based on just looking at them. Obviously if you're bleeding from your arm or your head or something like that, and it seems pretty significant, they're going to be brought right back in, or sometimes it's determined by their vital signs or how clearly they're thinking. And those patients are just brought back in, as opposed to somebody who maybe slipped in a hole and can be triaged over to X-ray to get some imaging studies, and we can provide them some ice and some pain relief. Obviously, two different levels.
Okay, so what happens to a trauma patient, and how is the hospital alerted that there may be a trauma patient coming?
So some of that does come from pre-hospital.
When you say pre-hospital, we're talking about Wally.
I'm talking about people like Wally. If Wally wants to speak to that a little bit about how he notifies us, then we can kind of lead into what we do.
What happens?
Okay, pretty much when Luzerne County dispatches any of the ambulances in the area, we get an idea of what we're going into. Once we get there, we assess, if it's a fall victim, are they on blood thinners? That's one of the big things now that we need to worry about, is the people are on Coumadin, and there's a lot of other new blood thinners that are out there. And a lot of people don't realize that it may be a simple, I bumped my head on the corner of a dresser, I'm okay, but with that blood thinner, there could be other bleeding going on. So that is one of the things that we've upped on with the trauma alerts, and that is the blood thinner side. And a lot of people really don't realize that it can be that important.
So Wally, when a trauma happens or something happens, would it be to everyone's advantage that if it's a spouse or if it's a child or whatever, or elderly person, to have the medical records available, so when you guys get there, okay, they know what that person's on, etc. Instead of, I think he's doing this, I think she's doing this, etc. I mean, whatever would help facilitate, the recovery faster, so to speak.
As much information as they can get written down, a med list.
So that is helpful.
That is extremely helpful, because the doctors need to know what they're taking. We need to know in the field, so that we're not giving them a medication that may interact with something they're on, and it'll help them make a decision once we get to the hospital what they need to do. And the allergies, any past medical history, if they've had cardiac caths, cardiac bypasses, stuff like that, that's all really important, and it helps them make the decisions on what we need to do with the patients once we get them to the hospital. But as far as notifying the hospital, once we get a picture of what went on, what injuries we see, then we call the hospital, whether it be on the radio or the phone, and explain to them, this is what we're looking at, and say, hey, this is a trauma alert by what we're seeing, and they will activate the nursing staff to be waiting for us when we get there.
So Wally, are all the people that work for APTS, are they trained? So if you're going to maybe, I think my husband's taking a heart attack, or she just fell, are all the people who are at APTS coming to wherever the place is, are they trained to know what to do?
Yes. We either have our BLS trucks, which are staffed by 2 EMTs, or our paramedic trucks, which is an EMT.
How do you know which one to send?
By what the emergency is and the information that is provided to us by 911. If it's vague, we'll send a paramedic unit just in case it is something that's worse than, and if it sounds something simple, then we'll send the BLS truck, and they're capable to go in, evaluate the patient, and if they see that the patient needs more medical care than they can provide, they'll call for a paramedic unit to back them up, and we'll take care of the patient from there.
So you already have a pretty good idea when you're on. So my question is, knowing the people who work at APTS, everyone who is hired is qualified and trained. You just don't pick people off the street.
No, we don't pick people
drive
off
the truck, but there's a person.
No.
Okay.
The EMTs, and right now we have 7 people that are in the EMT program up at Lehigh Valley Hazleton. They go through 120 hours of schooling, and then there's a state test that they need to pass to get that certification.
So we could feel safe that we have people coming that are trained and qualified, right, Gary?
I would say greatly so. I don't think they're just looking at people who maybe had pulled in their parking lot to get a job application.
Well,
and
you never know, but people are thinking, who's coming?
There's great relationships with, in fact, one of the things Wally just mentioned was the training. So we actually just, within the last year, I think, started what we refer to as Emergency Medicine Institute North, which is kind of a satellite campus of our main Emergency Medicine Institute down south, which is essentially, we hadn't talked about this pre-show, but what essentially is a training facility for pre-hospital providers. and sometimes nursing staff as well. So it's a classroom setting, it has models, so that they can go through and get various training to keep their skills up. So there's a lot of training and a lot of continuing education that goes on.
Yeah. All right. So now they bring them to you. Okay. They come up to the trauma center. You already know what's happening. What they're telling you, etc. So what happens then when they're brought to the trauma center?
Yeah. So just to build on that a little bit further, what Wally's talking about and what you were speaking to earlier. I mean, we have a set of criteria for those patients that need to be trauma alert. So it could be based on mechanism. It could be based on physiological signs. It could be based on provider discretion based on what they're hearing. And so they're made a trauma alert. And so what is brought to bear when a patient's made a trauma alert is a room is cleared. We have a resuscitation area for those patients. There's a dedicated nursing staff that will do recording of vital signs and charting. There's blood bank responds, radiology responds, CAT scan responds. An ultrasound machine is usually brought to bedside. The providers are prepared. So you're basically talking a team, usually no less than about 10 people, that are waiting for that patient, are there with that patient very soon after they arrive.
And that brings me, and I know the answer to this, but that brings me to the other question. So we know we have qualified, trained people coming to pick the person up. Now, when you have 3 shifts in your emergency department?
Correct, we have 3.
Well, I assume then that at the 3 shifts, you have qualified staff on the 3 shifts. So therefore, I would think, well, 2 o'clock in the morning, I don't know if they're going to have the qualified staff there. Something should happen. Maybe during the daytime, So tell me how your staffing is prepared for the incoming at any time throughout the day.
So all our staff is either board eligible or board certified by national accrediting bodies. And actually, everybody who's on staff right now is board certified. There's no new graduates that we have working with us that are board eligible. So they're all recognized by their accrediting bodies. In addition to our mid-level providers, they all go through their national credentialing. So everybody's nationally credentialed. In addition to that, the mid-level providers who would normally not get that type of trauma training, because the attending providers get that training as part of their residency and then have some continuing education requirements. The mid-level providers are also sent for additional trauma training. And that's just by us deciding to do it. That's not that's a little bit of a requirement, and then also because we want them involved with if they're going to be involved with the trauma, they need to have that. So we made sure that they got that extra training.
So you're secured on all areas, no matter what time you go into the
24
hospital.
hours a day.
Because trauma is trauma, and sometimes people think, well, they don't have this, they have this. I happen to know differently. Okay, you're well equipped. And I happen to know the qualification apps, but I want the public to know that they should feel secure in that. Folks, I'm talking to Dr. Gary Bonfante, who is the Medical Director Emergency. Folks, I'm telling you, it's amazing how they work. I had the I don't know if it's fortunate or unfortunate experience in the last 40 days to see them in operation, and I got to tell you. God bless them. That's all I could say. And also Wally Boyle, who is the Paramedic Coordinator. We come back, we'll talk a little bit more about initiatives and what's happening. So you are fully aware what we have available. Then what happens when you're there? When do they decide, well, this is really something, we have to send you to Allentown and we have to get the helicopter. We don't know what happens there. What are the criteria? Stay with us. Welcome back to the Sam Lesante Show, folks. Remember, 24/7, all of our programs on ssptv.com and in the Hazleton area, channel 13 and HD, as you know, 513, Comcast 190 in Pottsville, the Service Electric Communications 92 in the Wilkes-Barre-Pittston area, and also Lackawanna County, Comcast 190. My guest today, we're talking about the Trauma Center at the Hazleton Lehigh Valley Hospital in Hazleton. And my guest is Dr. Gary Bonfante. He's the big man here. He's the Medical Director Emergency. So if things go wrong, you call Gary up and say, Gary, this is going crazy. Wally Boyle, who is from A.P.T.S, Paramedic Coordinator. I'm only kidding, of course. So we talk about trauma. We talked about how Wally gets him up here. So let's talk about some of the local trauma initiatives. What does that mean?
Yeah. So Another thing, what you just mentioned, we always want to know how we're doing, Sam, so that's fine.
Oh, believe me, they'll tell you.
Yeah,
They'll
no
tell.
problem with knowing how we're doing. We always strive to improve. So some of the initiatives we've had, there was recently we did the ATV Initiative, another initiative which I think the community may want to know about.
What was the ATV initiative?
The ATV Initiative is we received a grant, so we actually filed for a grant and were awarded a grant that allowed us to provide ATV pre-hospital education to the public. And recently we had like an ATV simulator up here, just trying to teach safety. Basically, we see a lot of ATV.
You get a lot of those?
Oh yeah.
Yeah.
Unfortunately, we see a lot of ATV accidents.
No matter how much you educate them, okay, what to do and how to do it, some of these, they just get...
Well, I'd like to think that maybe we're making a difference with that because obviously we don't necessarily see the ones we don't see, right?
Yeah.
So I'd like to say that we're making a difference with that. The other big thing that we did was we worked with our colleagues down at Cedar Crest and with the head injury and concussion program. We've always had that available to us, but we formalized that relationship a little bit more. So now if somebody, for example, were to come into the emergency room and were to sustain a head injury, and we, after appropriate assessment, possibly imaging, we decided that they could go home. But they maybe had a concussion. Maybe they have a little bit of a headache. We're concerned that they may have concussion. We can now get them more clear follow-up with our colleagues initially down at Cedar Crest for their initial assessment, but the nice advantage to the community is now at the Health and Wellness Center, they have all the equipment to do the cognitive rehab that usually needs to occur with the concussion patient. So they invested that time, energy, and personnel to come up with this ability to have the initial assessment down in Lehigh, but now they don't necessarily have to go down there for their rehab.
Who are the ages mostly that get concussion?
I
know it could be everybody.
Yeah, it could be really varied,
a large
but
majority.
large majority is the teenagers involved in sports. Sometimes we get people who are working on their homes on the weekend, so 30, 40 years old.
I would like to have, and if you know Tammy, who's sitting over there, a show on concussions. Because I think there are a lot of things that people do not realize in the trauma. And my eyes were really open when I watched the movie Concussion. Mm-hmm. Okay, and I advise anyone to, did you see that? It was a fascinating movie. And I realize sports are sports, and that's another show for me, my own show. But there's, I think, a lot of damage being done to young people with sports. And people don't, and I think they're being pushed too hard. But that's another story. Because that's why I ask you, okay, concussions, because that could be a serious situation. Okay?
Yeah, and like I said, the program's really been growing, and what we do is we send...
It's great that you have that.
We send the referral down there. The follow-up now, they will actually contact the patient themselves. They'll set the follow-up appointment at a time that's convenient. They can go down there for their initial assessment, and then all the rehab that may need to be done can be done up here, which is really nice for the patient because they don't have to travel back and forth like they used to. Yeah. So just another service that Lehigh Valley is bringing to the community.
So before I get to Wally, I want to talk about the relationships, what EMS relationships are. When do you decide, a stupid question, but when do you decide if the trauma victor is there when you have to send them maybe down to Allentown?
No, actually,
has that ever happened?
No, it happens frequently, Sam, and I think that's actually a really great question because, and I think it's important to explain that because we are, again, have full capability to do this resuscitation, initial assessment, but there are certain services that obviously in a community hospital you're not going to have available to you. They're just specialty services that are only going to be found in big centers. And that, we could probably talk about the economics of medicine all day, but the reality is certain things are just going to be found at bigger centers, as much as we try to bring up here. Because you got to get the specialists to come to those centers, right?
Question, yeah.
So if somebody's severely injured, so you say, for example, they have a collapsed lung and an injury to their spleen or their liver, they're basically a multi-system trauma now. They maybe have a head injury on top of that. That patient is going to be best served at the level 1 trauma center where we have a relationship, so those patients will be transferred quickly. This is as opposed to somebody who maybe fell down some steps and has a couple fractured ribs and needs to be admitted for pain management, whereas we may have not have kept that patient before who just needs some pain management because they have the fractured ribs. As a level 4 trauma center, we'll keep them now so they can stay close to home. But when that requires a higher level of care that maybe has services, it's best for that patient to go to the level 1 center. It's best for them to come to us first for us to assess that and stabilize that. But then a lot of times we need to get them out of there. And that's where we have a close relationship with Wally and A.P.T.S. and Medevac, because we know we need to get those patients out of there, sometimes before we even complete further diagnostic studies.
Do you utilize the telemedicine?
For trauma, we don't.
Okay.
You know, sometimes for stroke, but quite frankly, we know that group down there so well, and they've become so comfortable with our skills that a lot of times it's a phone conversation.
Yeah, I mean, it's fabulous. I mean, you're right there. Okay, Wally, discuss the importance of EMS relationships in our community.
Well, the important thing is for people to understand, you know, what we do. There's been a big dogma that we're just ambulance drivers. You know, like we touched on earlier, there is a lot of training. We have the EMI North. You know, we do have continuing education that we do, you know, that we require as A.P.T.S, that the state requires each individual provider to do. Within a 2-year period, I, as a paramedic, have to do 36 hours of continuing education to continue being a paramedic. The EMTs have to do 24 in 3 years. But so that's, we're really trained. And with the Level 4 Center, I'm involved with the monthly meetings over, how we're doing with trauma services, how my guys are performing and bringing these in, how the communications are going on. So, we've gotten involved, as far as that. When we are bringing these patients in, if we feel that they're going to have to be transferred and the weather's bad, that the helicopter can't fly, my crew will stay at the hospital till that decision's made that they need to either use my truck to get them to Lehigh, or if we're using my truck with the Medevac crew, because we do have a relationship with Medevac, that if that helicopter can't fly, we'll put their crew on my truck, so you'll get that higher level of care, the critical care that they provide in my ambulance to get them to Lehigh Valley. So, we've built that relationship between Lehigh Valley, Hazleton, and the Medevac program.
So what I'm seeing here, from start to finish, there is communication, there are trained people, they're going to the appropriate place, and they're being taken care of the way they should be taken care of when they hit the hospital,
Right.
Okay? So I'm seeing from the mere fact that you guys hit the scene or whatever it may be, people should really feel comfortable. Right. Go ahead, Gary.
They should, because we just recently were re-inspected by the state, and we received a 3-year accreditation. That's the most that any facility can obtain, even if you're a Level 1 center. The most you can obtain right now is a 3-year accreditation.
Dr. Valente was on the show, did a great job explaining a lot of these things, accreditation. So people sometimes, accreditations, they come in, they give you a rubber stamp, and they walk out the door, okay?
Yeah, not this one. Not this one.
So, I mean, it's a serious matter, correct? Yes. So explain what actually you got to go through. It's just not like if it's a political thing or whatever, because, people think differently.
I'll try to explain it to you briefly. But essentially, we're notified by the state when they're going to perform an inspection. We need to be able to provide them things such as, what is our PI process? How are our nurses?
What's
PI? Performance improvement.
Okay.
How do we review our charts? How do we review patients who, unfortunately, patients from trauma sometimes die? So how do we review our mortalities? Do we identify things that we could have done better? And if we could done better, and we've identified that, how have we responded to that? So have we actually improved the process, which the state actually gave us a little bit of an informal accommodation, a little bit of an informal kudos,
okay,
if you will, on how well our PI process is.
A little pat in the back. And the certificate.
Yeah, as well.
Okay,
and they review our charts as well. So they'll review about 25 to 30 charts of patients and see how we actually performed for that individual patient. So it's a pretty arduous task in what we go through.
Wally, how long have you been with A.P.T.S?
I've been with A.P.T.S 15 years. I'm in EMS.
So
33.
in 15 years, okay, as well as I've seen the advancements that Lehigh Valley Health Network has brought to the area, okay, so people understand from your perspective, going back 15 years and coming today. I mean,
it's gotten a lot better. It really has. I mean, our relationships have gotten much better. We can work together.
Mm-hmm.
They really look at, what we tell them is pretty much what if their eyes were looking at the patient. So, they do pay attention and they do work with us. And because we have this tight-knit relationship, it's the patients that benefit in the end and get the best quality care that they can get.
So working with Cedar Crest, okay, so the relationship between Lehigh Valley Hospital here at Hazleton and helping with you guys, how does that work with the Cedar Crest provider, with the EMS providers?
We have a really good relationship with Cedar Crest. You know, when all this started, that's where a lot of our training came with the MI program. You know, we started working with Cedar Crest, and you know, as they came and took over Hazleton, you know, they brought all of that to us, so we were already into the program with that.
Very quickly, when I had the helicopter people, or the medevac. Okay, what could you determine or have I don't know, when you're picking a person up? Can you say, I think this person has to go down? Because I know they have in the helicopter, it's a whole hospital in itself.
Right.
Okay, so you have pre-knowledge of that. Okay, so in having we have about a minute and a half left, Gary. Talking to Dr. Bonfante, folks. First of all, your crew is absolutely fabulous. Okay, and please send my thanks because they were really great. Okay, and I could assure. Now, sometimes people expect, you know, miracles, but you guys do. You girls and guys do a fabulous job.
I'll let them know.
Seriously, I mean that sincerely. I wouldn't just say that. Okay, and A.P.T.S has been always trained, etc. We're very fortunate, Gary, I think, in our area. Just in a summary, about a minute, the Trauma Center, explain what it is.
So the Trauma Center is basically a state-accredited center that provides advanced levels of care beyond that of a regular emergency department, just their typical emergency department. We have to meet a certain criteria. We have to be able to show that we're doing performance improvement. We have to show that we're doing community outreach. So it's a higher level of care.
And you met all your certifications, all the qualifications.
We have. We're good. We're good for 3 years right now, but it doesn't mean we're gonna keep checking and making sure we're still on the mark.
Well, like I'd say to you, Dr. Bonfante, keep the good work up, okay? And Wally, give the best to all those people that work. They really, it's a challenge sometimes, folks. I'm talking to Dr. Bonfante, who is the medical director of emergency at the Hazleton Lehigh Valley Hospital, Hazleton, and also Wally Boyle, who's the paramedic coordinator. You have any questions or comments, folks? You could always go to their website, but I could tell you this. Their number is it's an easy number, it's 501-4000. And if you want to make an appointment with them, it's 501-4LVH. Thanks for joining us. We'll see you next time.